Kita mulai ya, Prof. Dok. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Good morning, everybody, esteemed members of the Indonesian Radiation Oncology Society, or IROS, and distinguished participants, our colleagues, radiation oncologists, perhaps from other countries this morning, and also colleagues from other disciplines. It is a pleasure to greet you all this morning. Welcome to our webinar today. It is the first webinar of the new series. The series is called Thoraco-Pediatric-LymphoMusculoSkeletal TPL series, hosted by IROS. And our topic today is entitled Radiotherapy for Soft Tissue Sarcoma. And this series are our new educational events to represent our commitment to advancing knowledge and sharing in the field of radiation oncology and beyond. At IROS, we emphasize the significance of continuous learning and international collaboration and support. And this webinar exemplifies our dedication to providing access to expertise from across the globe and promoting exchange of ideas and experiences, not only in radiation oncology, but also with a multidisciplinary approach. So today we are honored to have Professor Siddhartha Laskar from Tata Memorial Hospital, India. Good morning, sir, as our esteemed speaker for today's session. His expertise in radiotherapy includes sarcoma, among many others, promises valuable insights and perspectives for all of us today. We also extend our gratitude to the panelists, Professor Fauzi from Orthopedic Surgery, Dr. Anamira, our medical oncologist, Dr. Marcel from Radiology, Dr. Evelina from Pathology, and our own radiation oncologists, Dr. Umi and Dr. Handoko. And also all colleagues who have joined us, thank you for contributing your expertise to enrich our discussions later. And we are reminded always that effective cancer treatment relies on the synergy of multidisciplinary teamwork. To begin our session, I invite the president of IROS, Dr. Ben Prajogi, to please give his welcome remarks. Please, Dr. Ben.
Thank you very much, Dr. Mayang. So, good morning, colleagues. Very happy to have everyone here this morning. It's a very nice day. As Dr. Mayang has informed earlier, this is a new initiative from IROS. We are going to approach the CME and CPD in three major groups now, in accordance to the availability of specialized expertise in our society now. And we have been blessed with a lot of friends, very good friends, experts worldwide, who are willing to contribute to the development of radiation oncology in our country. And that is what we are leveraging in this new initiative. I would like to thank Professor Tati, Dr. Mayang, and Dr. Handoko for developing this idea for our CME and CPD approach, which I think is very cost effective. And I appreciate everyone for participating and setting aside their time in their weekend to further improve their knowledge and skill. And to our panelists, particularly to our speaker for today, Professor Laskar, thank you very much. We recognize your global expertise and really appreciate your friendships up to today. And we look forward to listening to your talk this morning. And for our colleagues from Dharmais Cancer Hospital, Dr. Umi, thank you very much for joining. Also for our colleagues from the musculoskeletal team of Cipto Hospital, Professor Fauzi, Dr. Anamira, Dr. Apple, and Dr. Marcel, thank you very much. Looking forward to the discussion later. Next, I would like to pass over to Professor Tati to give a general overview of this session as the chairman of the subspecialist group for TPL. Please, Professor Tati. Thank you.
Thank you very much, Ben. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera untuk kita semua. Hello everyone. Good morning from Jakarta. Actually, I'm not in Jakarta. I'm in some countryside of Jakarta on the way to some place outside of Jakarta. But sorry if the Wi-Fi is not always good. So welcome to our webinar this time. This webinar is a special one, as it is already mentioned by Dr. Mayang and Dr. Ben, as we, for the first time, introduce our new webinar series. The name of this series is the Thoraco-Pediatric-LymphoMusculoSkeletal, or we call it as the TPL series. As we know that in radiation oncology, our field is growing very fast, and it is our responsibility to keep up with the latest advancements. That's why we are starting our subspecialty group under the IROS to allow more opportunities for learning and improvement through this subspecialty group. We aim to foster an environment of focus, learning, collaboration, and shared expertise. So, starting this day, our webinar will be designed by each group, starting with us, the TPL. So I belong to the TPL group this time, and it will be followed by the series from the other groups. We have also CNS, head and neck group, and abdominopelvic group. Today, as it is mentioned, we are honored to have with us Professor Siddhartha Laskar from India, from the Tata Memorial Hospital, the very famous cancer center in the world. And we already know that he is a long-time trusted friend and an expert in radiation oncology. Hello, Laskar. Hello, Siddhartha. His valuable insight will undoubtedly enrich our understanding of the topic. Thank you, Prof. Laskar, for always kindly supporting us every time we need your help. I want to extend also my thanks to all the panelists, if it is mentioned already, from different disciplines who have joined us today to show how we should work in the field of oncology as a multidiscipline team. So a cancer patient cannot be treated just only with one discipline. That's a very basic concept that we know already, that it should be discussed from the beginning in the multidiscipline team. We have here, as it is mentioned, Prof. Fauzi from Orthopedic Department, Dr. Marcel from Radiology Department, Dr. Evelyn, or we call it Apple, from Pathology, and also our own Radiation Oncology Fellow, Dr. Umi and Handoko. Your expertise and diverse perspective will significantly contribute to the success of this webinar. To all our colleagues from Indonesia and neighboring countries, I'll be waiting to hear your active participation in this webinar. This is our chance to show how is our commitment and dedication to always push excellent in-patient care, especially for our patient, of course, to our disciplines. Let's embrace this opportunity to learn, grow, and collaborate. Together, we can make a positive impact on the life with a good quality of our patient. Again, thank you again to our best friend, Professor Laskar, for being here, for sharing, discussing in the topic of soft tissue sarcoma with us. Thank you all also for being here. Hope you enjoy this webinar. Thank you very much.
Thank you. Thank you, Prof. Tati. Now, let's take a picture first in the panel room. I think everyone has already turned on their videos. So Dr. Dika, you could proceed to capturing the picture.
Okay, dear respected Prof and doctors, my name is Dika from IRORA, Indonesian Radiation Oncology Resident Association. First, I would like to thank you for joining our webinar today. Now I will assist you in taking our group photos. The picture will be taken twice. So kindly turn on your camera and please hold still for a brief second so we can get a clearer picture. Okay, 1, 2, 3, smile. Okay, once more. 1, 2, 3, smile. Okay, back to you, Dr. Mayang.
Thank you, Dr. Dika. Okay, now, before we begin, may I remind all participants of our Zoom features. At the bottom of your screen, you could find the Q&A box. You could type in your question at any time during the webinar. Please put also your name and institution or country. And if time allows us, we will discuss all your questions at the discussion session. And at the interactive session, if you would like to speak directly for a question, you could also click the button raise hand and we will allow you to speak on your turn. Now, without further delay, let us now delve into the webinar. I humbly invite Professor Laskar to start your talk. Please, Prof.
So thank you very much, friends in Indonesia. It's always such a pleasure to be part of your academic sessions. I know Indonesia is a warm country, but it's not only warm in terms of temperature, but the love and affection that you all show is amazing. Besides that, I have to tell you that I think yours is one of the most active organizations in terms of academics, and congratulations to you for pushing academics in a continuous and a uniform manner so that everyone benefits. You did mention that we are experts and we share a lot, but I can tell you that every time I speak in your forum, we do learn a lot of things. So it is a mutually beneficial field. And I hope that we continue this association, and I would definitely love to continue this association. So, and thank you specifically to Prof. Tati. Prof. Tati, you've been amazing from the times of Dr. Dinshaw. Our relationships have grown. They've grown only stronger. And then we have many of our other colleagues who came in, Mayang now, Ben, Handoko, we got in touch last exam time. And of course, now I'm so happy to see the multidisciplinary team from the orthopedics team. I'm sure you are familiar with our orthopedics team in TMH, Dr. Puri, Dr. Gulia, Manish Agarwal. The pathology team, I'm sure you would have met Mukta or Bharat Rekhi, who are experts in pathology. We also have an active radiology team, and we are fortunate to have a very active multidisciplinary team where we discuss issues, and we also fight at times, but with academic interest. So, so it's great to have a multidisciplinary team. And Mayang asked me to speak on soft tissue sarcomas and the current status of radiotherapy with the current evidence. So I'll share my screen now. I hope my screen is visible.
Yes, we can see it.
Thank you. So. Okay, so greetings to you from Tata Memorial Hospital in Mumbai. We started off in 1941 with just one hospital in Parel in Mumbai that you can see now on the left of your screen. But now we have grown as Tata Memorial Center with one additional center called ACTRAC, which is also the Advanced Center for Treatment, Research and Education in Cancer, which is located about 30 kilometers from our current location. Besides that, we have spread out all across the country. Now we have 7 satellite centers all across the country to ensure that patients from all over the country gets the benefit of our hospital, our organization. So in the remaining 30 minutes or 40 minutes, I will discuss with you the radiation therapy for soft tissue sarcomas. And I just tweaked the topic rather than the current evidence. I just named it the evolving evidence. In order to understand the current evidence, it is very important to also look at how we have evolved, and that would make us better understand what we are doing today. So as you can see here, soft tissue sarcomas comprise a whole lot of a wide range of histological types of tumor that arise from various tissue subtypes, like fibrous tissues. You have the fibromatosis and dermatofibrosarcomas. You have other more common tumors like the liposarcomas and the malignant peripheral nerve sheath tumors. We also have in this group of tumors the predominantly bone tumors, which are the extraskeletal osteosarcomas or chondrosarcomas and mesenchymal chondrosarcomas. And of course, there are some other tumors which you would frequently come across, like the alveolar soft part sarcomas, clear cell sarcomas. Synovial sarcoma is a very common subtype. Now, all these subtypes broadly, in terms of treatment and the natural histories, are broadly divided into two groups, which is the non-round cell soft tissue sarcomas and the round cell soft tissue sarcomas. Now, it is essential to differentiate between these two groups because their natural histories are different. The patients are different in terms of age group, and of course, the treatments are also very different. So today we will talk about more about the extremities non-round cell soft tissue sarcomas in order to keep the focus and also have more time for discussion. As you can see from this diagram, soft tissue sarcomas are seen in literally all sites of the body, and the majority is comprising of tumors that arise in the extremities. We also see them in the retroperitoneum, GI tract, and the head and neck region, but we are not going to touch on the other sides today. We will focus primarily on the soft tissue sarcomas of the extremities. Now, if you look at the treatment of soft tissue sarcomas, it has primarily been surgery. And we will see how the surgical things have also changed. It used to be ablative surgery like amputation and compartmental excision, very ablative surgeries. And now we have gone down to less ablative surgeries, which leads to organ and function preservation. Now, this was a very important statement made by William Enneking, who is a surgical oncologist and has contributed greatly to the development of treatment of bone and soft tissue tumors. And what Will Enneking mentioned was that the value of adjuvant radiotherapy is in extending the margin of limb salvage surgery that otherwise has a high risk of recurrence. So it is so apt that he made this statement long back, and this statement still holds true. And we will see how radiotherapy has contributed in improving disease control and also improving the chances of limb salvage surgery and functional outcomes of treatment of bone and soft tissue tumors. Now, broadly, if you look at what happens if you just do surgery for soft tissue sarcomas. Now, this is old data, but it has not really changed that much from the time these data was published. If you look at the outcomes in terms of local recurrence rates after surgery, if you do an amputation or a radical resection or a compartmental resection, the recurrence rates are anywhere between 4 to 18 to 20%. If you do a wide local excision, that means you resect the tumor with a margin of normal tissue around, and we can talk about the margins later on, the recurrence rates are anywhere between 20 to 30%, and sometimes it is very unusual to have higher recurrence. But if you have a marginal resection where you are cutting through the reactive zone of tissue, then the local recurrence rates increase. So broadly, if you do a very extensive surgery, which is mutilating, which has got functional compromise, the local controls will be good, but you will have significant functional compromise. Whereas if you try to conserve the limb by doing less extensive surgery, then the local recurrences increase. And that is where radiation therapy comes into play to avoid or prevent the recurrence of tumors. Now, let us look at evidence. Now, it is very important that we go by evidence. Do we have strong evidence to say that it is safe to do limb conservation while you were actually doing amputation for soft tissue sarcomas earlier? So this is the only randomized trial, although very small, of 43 patients. 16 of them had amputation and 27 of them had limb sparing surgery and radiotherapy. And the doses have remained the same, 50 gray for a wider field, followed by 10 to 15 gray boost. Now, all these patients also received chemotherapy with doxorubicin, cyclophosphamide, and high-dose methotrexate. If you look at the local recurrence rates after a follow-up of 56 months, which is long enough, in the amputation group, obviously, we would not expect recurrences. In the limb-sparing surgery and radiotherapy group, the recurrences were 14%. But there was no difference in survival. That means these patients could be salvaged. And this was probably the earliest randomized evidence that was available to tell us that an individual need not undergo amputation for a soft tissue sarcoma, but a limb-sparing surgery in the form of wide local excision and radiotherapy could give you equally good disease control. And this finally led to the consensus conference and the consensus development that conservative surgery and radiotherapy is the standard of care for high-grade soft tissue sarcoma. Now, things have moved on from that point. This was the first evidence to say that amputation is not required. But the second thing that people wanted to know is that does radiotherapy actually improve local control or doesn't it? So this was a study that came from NCI, was published in 1998, which included 141 patients, 71 had limb-sparing surgery and 70 had limb-sparing surgery and external radiotherapy. And the doses of radiotherapy was again the same, almost 60, 63, 64 gray, cumulative dose of radiation to the tumor bed. And if you look at the local control, in the limb-sparing surgery alone group, the local control was 76%, whereas in the group having surgery and external beam radiotherapy, the local control was 98%. Now, this showed that there is a significant improvement in local control if you are doing limb-sparing surgery and radiation therapy, and this was statistically significant. So this was the second big important study that told us that limb-sparing surgery and radiotherapy is the standard of care. But does it have the same impact in both high and low-grade tumors? Yes, it does improve the local controls in low-grade tumors also, but the magnitude of improvement in low-grade tumors is lesser than the magnitude in high-grade tumors. And what was also seen is that brachytherapy, the benefit of brachytherapy was probably not as much as in the low-grade tumors compared to the high-grade tumors. So this was another important information that came to us at that point in time from the NCI trial. Now, once we know that we need radiation and radiation improves local controls of disease while preserving function, we also wanted to know what is the best time to do radiotherapy. Is it better to do preoperative radiotherapy or is it better to do postoperative radiotherapy? Now, if you look at the theoretical advantages and disadvantages of each, when you're doing preoperative radiotherapy, obviously there is less chances of contamination, blood tracking into the surrounding normal tissues, the non-tumor bearing area. So because of that, the field size that we would require is smaller, theoretically speaking. The second advantage of preoperative radiotherapy is that it requires lesser radiation doses. Now, theoretically, again, since we are dealing with an area where the vascularity is maintained and not compromised by surgery and other interventions, we assume that the doses of radiation that is required is less than the patients who have postoperative radiotherapy. So you will see later on in the slides that when you do preoperative radiotherapy, most people would do doses of 50 gray, whereas you're doing postoperative radiotherapy, most would do between 60 to 66 gray based on the margins. The other advantage of preoperative radiotherapy is that it delays the time interval between surgery and radiotherapy. Now, sometimes after surgery, wound healing is an issue, and then you have to delay radiotherapy. So theoretically, it also eliminates that delay between surgery and radiotherapy. It also is expected to limit dissemination of viable tumor cells because they sterilize that area and maybe form a capsule kind of thing, which prevents dissemination of viable tumor cells. Now, this is not been proven, but this is a theoretical hypothesis that preoperative radiotherapy reduces the chances of distant metastasis or dissemination of tumor cells into the regional lymph nodal areas. And the last thing is, when in borderline resectable tumors, it probably improves the resectability by giving the surgeon a plane through which you could safely resect. While if you did not do radiotherapy, you could possibly end up with a microscopic positive margin. So those were the advantages of preoperative radiotherapy. Now let us see what are the advantages of postoperative radiotherapy. Now, one of the most important things that people would talk about in postoperative radiotherapy is that it allows tailored radiotherapy field size based on your surgical and pathological findings. So if you've done your surgery, your surgical margins are negative, you have a clear idea about the extent of disease, you can plan your fields accordingly. You also have pathological information on the surgical margins, whether it is R1, R2, R0, and also the histological subtype of tumor. Although we do not currently change our radiation doses based on the histological subtype, but maybe in the future, some of the tumors that are more sensitive to radiotherapy, in them, possibly the doses of radiation, post-op radiation that we recommend would probably reduce. The third thing is that it delays the primary treatment. Now, we consider surgery to be the primary treatment for most important treatment. And what postoperative radiotherapy does is that it prevents or it eliminates the delay in resection of the primary tumor, which is again very important. And of course, at the end, we will discuss about this later on, the possibility of eliminating radiotherapy in low risk or low grade soft tissue sarcoma. So you could possibly avoid giving radiotherapy for a select group of patients. So these are the broad theoretical advantages of preoperative and postoperative radiation therapy. But do we have clinical data to tell us which one is better? We actually have only one randomized clinical trial addressing this question of preoperative versus postoperative radiotherapy for extremity soft tissue sarcomas, which came from Dr. Brian O'Sullivan's group in Canada. So they had 190 patients of extremity sarcomas. 94 had preoperative therapy followed by limb-sparing surgery, and 96 had limb-sparing surgery followed by post-op external radiation. Like I mentioned earlier, the pre-operative radiotherapy group received 50 gray and 25 fractions, and the post-op radiotherapy group received 66 gray and 33 fractions. The end point of this study was to look at complication rates between these two groups. And the secondary endpoints, of course, had local control and survival. So if you look at the primary endpoint, after a median follow-up of 3.5 years, the wound complication rate was greatly different between the preoperative group and the postoperative group. The preoperative group had 35% wound complications, whereas post-operative group, there was much lesser. So that is one thing that one needs to remember, that the complication rate would be high. In terms of disease control, local control, the disease control locally was same in both groups. But surprisingly, the overall survival seemed to be better in the group receiving preoperative radiotherapy. This could be possibly an indicator of cell dissemination that is reduced, but that has not held for a long follow-up patients. So we are not very sure whether it truly improves overall survival, but in this study it did. The other important things were in the post-operative RT group, the incidence of fibrosis, edema, and joint stiffness. These were higher in the post-operative group. And the argument was that because the field sizes were larger and the doses of radiation were larger, we ended up with more fibrosis, edema, and joint stiffness. But in a later analysis done later on by the same group for the same group of patients, it was found that these differences in fibrosis, edema, and stiffness did not hold. They were same in both groups. So with that information that the local controls are good, it is lesser doses of radiation, but the wound complications are higher, the same group went on to take another study where they got the operating surgeon on board, and they tried to identify the area that the operating surgeon would have the incision. And they used intensity modulated radiotherapy and identified the area that would receive high dose radiation and plan the surgery accordingly so that they would resect that area of high dose radiation so that the wound healing would be better in this group. So they published their outcomes and they compared the outcomes of wound complications between the SR2 study and the current study of flap sparing intensity modulated radiotherapy. And what they found was that the complication rate was much lesser when you spared the flap from high dose radiation therapy, or you resected the flap out area receiving high dose radiation therapy. And what was also seen is that when you did IMRT, the joint stiffness rate, as you can see in the lower part of the table, the joint stiffness was much lesser in the group receiving IMRT compared to the SR2 trial. The edema was more or less the same, but the subcutaneous fibrosis was also lesser. So the message that goes out from these two studies is that preoperative radiotherapy and post-operative radiotherapy are equally efficacious in terms of local control. But in order to reduce the chances of wound complications, one needs to use technology in order to reduce the dose to the areas where you would have the surgical incision. And also from the surgical point of view, to resect out that area of tumor of the subcutaneous tissue and skin that would have received high dose of radiation so that the complications rates are lesser. So these were important things that we got to know about preoperative and post-operative radiotherapy, both theoretical and the outcomes data from the SR2 trial and the IMRT study. There have been other studies also that looked at these parameters. And if you look at pre-operative group here and the post-operative group here, and if you look at the wound complication rates, generally, for most preoperative groups with large number of patients, you would find that the complication rates, wound complication, is anywhere on an average around 30%. Whereas in the post-operative group, the wound complication rate is around, so it is lesser in the post-operative group. But this could change if you're using techniques like IMRT, the flap sparing techniques. So that is one very important thing to remember when you're deciding on policies, whether you want to go by the pre-op treatment policies or the post-op treatment policies. In our hospital, in TMH, most of our patients would be evaluated for post-op, and that is because we try to do interstitial brachytherapy for our patients, and only those patients who have borderline resectable tumors or we have a delay in the surgery, in those situations, we try to use pre-op radiotherapy currently. Although globally, many people, many centers have actually transitioned to preoperative radiotherapy as a standard of care. In our hospital, we still stick to post-operative radiotherapy, primarily because we are so inclined towards doing interstitial brachytherapy for our patients. So how does it help? Conformal radiotherapy. Let us look at this target volume that you see for a patient with a thigh soft tissue sarcoma. So the target volume, as you know, is the area that we define based on the imaging and the surgical clips that we put, and we include the surrounding edema and the probable reactive zone, which may have microscopic disease. But the problem is, and the main OAR that we talk about is the femur and the other bones in the extremity. And we are worried about wound complications and also bone fractures that can happen in these patients. So does conformal radiotherapy and IMRT help? Now, this is an important and interesting study. It was very simple, but a good study where they looked at how one could reduce the volume of normal tissue. And in this case, the normal tissue that we are talking about is the bone and also the surrounding soft tissue. These are the two OARs that we are talking about here. And the same target volume was planned with conventional 3D conformal radiation therapy and IMRT, and the results were compared. Now, if you look at the PTV coverage, now PTV coverage between the IMRT group and the 3D conformal group is more or less the same. Both D95, volume receiving 95%, they are more or less the same between the two groups. But there is a difference in the dose that has gone to the femur, that has gone to the soft tissue, and that has gone to the skin. Now, all these three functions can impact on complications. Now, there is a significant difference between the dose to the femur. It's 44.7, 3D CRT, and 18, so a significant reduction. The low dose remains the same. And similarly, for the soft tissue, there's a significant reduction in the high dose that is going to the soft tissue when you're using IMRT or highly conformal therapy. And that also applies to the skin. So really speaking, when you're doing IMRT, if you have the resources available, then you can significantly reduce the dose to these OARs, which primarily in the extremities are the bones, the soft tissue, and the skin. And these would finally translate into an improved local control and also reduced complications. Now, what is the critical volume? Now, these are two relatively old series, but they have addressed important issues. Does reduction in radiotherapy dose translate into an improvement or reduction in fracture rates? And the second study looked at whether there was a relationship between the length of the bone that was radiated and the volume that was radiated to the development of bone fractures. And as you can see in the conclusions, they are not very large numbers of patients, but still they gave us the information that patients treated with EBRT after surgery for extremity sarcomas, the crude fracture risk is about 6 to 7%. And you would notice them on all series that are looked at fractures, that the fracture rates in these patients who received RT is on an average about 6 to 7%. So what are the factors that increase? What they also saw is that if the doses go higher up, the incidence of fractures do increase a little bit. You can see here between 50 and 66 gray, there is a difference about 8%. So there is an increase. So reduction in the volume of normal tissue does improve or does reduce the chances of fractures. So that same thing is seen in the other study also where they looked at the relationship of the long bone that is radiated, and they gave this the conclusion that the risk of radiation-induced fracture reduced if the V40 was less than 64%, and also that the incidence was lower when the mean dose was less than 37 gray, and the maximum dose anywhere along the length of the bone was less than 60 gray, 59, 60 gray. So these are broad impressions. It is not that we have to really strictly do that, but we should try to achieve these so that the complication rates are as less as possible. Now that we moved from 3D conformal and we are saying that IMRT is better, but do we have a head-on comparison of IMRT versus 3D or conformal radiation, conventional radiation therapy for extremity soft tissue sarcomas? Now, we do not have randomized comparison, but this is a nice paper from Alectiar's group that was published in 2014, where they looked at their series of patients who were treated with conventional radiation compared to their series who were treated with intensity modulated radiotherapy. And they compared them in terms of disease control and also looked at the complication rates. Now, in terms of disease control, surprisingly, the patients treated with conventional radiotherapy had a higher local recurrence rates. You know, it was almost double. And I'm a bit surprised why with conventional radiotherapy, where you have larger fields, the local recurrences would be higher. But it was a finding in this study that the IMRT group had lesser local recurrence compared to the 3D conformal radiotherapy, where the local recurrence rates were 15%. Now, the disease-free survival and the overall survival were not significantly different, but this was really different between the two groups. So the group in MSKCC, they do try to do IMRT for their patients, and they do preoperative IMRT for most of their patients. Now, between the two groups of conventional and IMRT, when you look at the wound complication rates, the wound complication rates were more or less same between the conventional and IMRT. But what was really different and surprising is that the nerve damage was actually higher in the IMRT group compared to the conventional group. So I would assume that it is not only what radiotherapy technique that you did, it was probably how complicated the surgery also was, and in terms of nerve handling and other things that we would have done. But one thing that was again surprising is that for conventional radiotherapy, 11% had joint stiffness, whereas with IMRT, it was 14%. So somehow, you know, because of the inherent biases that we have in non-randomized study, it is difficult to compare this, but we do have some information on how patients treated with conventional radiotherapy and IMRT fare in the same institute, treated by the same set of people. So we really don't have randomized data to tell us more about the comparison. So just quickly going through the target volumes for the residents who are there. The GTV, as you all know, is what is on examination and on radiological finding. The CTV in soft tissue sarcomas include the tumor bed. One would tend to include the scar. It is very important that we have the appropriate scars done by the surgeons. If you have an inappropriate scar, say, for example, you have a transverse scar going across the limb, that would end up, you would end up treating the entire limb circumference, which would lead to edema and other complications. So it is extremely important that the entire team is actually trained, and surgery also needs to be done by specialists and in a center that is experienced in doing these tumors. The drain sites, again, is very important. We say that the drain sites could be contaminated with microscopic cells, and hence that should be included in the radiotherapy portal. But if the drain site is located far away from the site of the scar, then again, you will end up increasing the tumor volume or the CTV unnecessarily. So it is extremely important that you have the surgeons who are really trained and put the scars at the right site. And the drains normally are recommended to have just adjacent to the one of the ends of the incision, so that in case tomorrow we have to do a re-excision, we can excise the scar or the drain site without causing too much of tissue deficit. The microscopic tumor extensions need to be included, and that is why you need to have imaging in order to see what is the extent of disease. And also, especially in patients where you have had, you're doing post-operative radiotherapy, you need to include the areas that have been handled during surgery. So a collaborative effort between radiation oncologist, radiologist, pathologist, and the surgical team is extremely important in order to have the best outcomes, even for defining the CTVs. Another important thing is when you're defining the CTV, please do not always go by the clips, because sometimes the clips are not tumor defining clips. They could be clips that are used for vessels. So you should discuss with your surgeons. And of course, the PTV margin would depend on the center and what is the most appropriate for your center. Now, why that margin? What is the basis to decide that a margin of 5 centimeters from the gross tumor is required in phase 1 and a margin of maybe 2 centimeters in the phase 2, where you escalate the dose to 60 or 66 gray? Now, this is an interesting publication where they looked at the tumor, and they looked at how far beyond the tumor you are able to identify microscopic cells. And what they found was that almost 67% of the patients actually had microscopic tumor cells beyond the grossly visible tumor. And when you look at the distances, most of them, 40% of them, were within 1 centimeter. And beyond 1 centimeter, it was 26%. And beyond 4 centimeters, they actually had very few tumor cells visible. And based on this, we actually say that the phase 1 of our portal should be about 4 to 5 centimeters for high-grade tumors. And for the phase 2, you have a 2 centimeter margin from the gross tumor, and you boost it to 60 gray. And that was the basis of why we have this thing of 5 centimeters and 2 centimeters for high-grade soft tissue sarcomas. Now, does it make a difference? This was a retrospective study. When you had a margin of less than 5 centimeters, the local controls were lesser. But when you had the phase 1 margin of 5 to 9 centimeters, which is very large by today's standards, the local controls were much better. But broadly, what it tells us is that appropriate margins is important. But the question now is, does it hold true now also? It is multifactorial. Your initial imaging with the radiologist, the discussions, the pathology discussion, and also the discussion with the surgeons is extremely important. And that has changed things. It is primarily all these factors put together, because of which the current margins that people are talking about is much lesser. Now, these are 2 trials that looked at what is the most appropriate tumor margin, the CTV margin. Is it 5 centimeters or is it 2 centimeters? Now, the interesting one, if you look at this Vortex trial from the UK, what they did was they randomized their patients into 2 arms. The arm A, the standard arm, was CTV with 5 centimeter longitudinal margin for phase 1 and a 2 centimeter longitudinal margin for phase 2. In the phase 1, and they would do 50 gray and 25 fractions to the large volume. And in the phase 2, they would do 16 gray and 8 fractions, and that leads to 66 gray. In the experimental arm, they did 2 centimeter margin, and they gave 66 gray and 33 fractions. So the dose was same, but look at the outcomes. The outcomes were more or less same between the 2 groups. So there is an indication that 5 centimeter margin, even for high-grade sarcomas, is probably not required. Now, what about the timing? Sometimes, surgery, you've done your surgery and it gets delayed, the wound healing is delayed. So is there a cutoff where we say that radiotherapy will not be effective anymore at this point if the margins are negative. So this is a study where they looked at, it's a French study, relatively large number of patients. Broadly, they divided their patients who received RT less than 40 days, 40 to 70 days, 80 to 100 days, and more than 120 days. And they looked at local relapse and survival. And what they found was that there was no significant difference between the outcomes in terms of local control and survival between the patients who received radiation immediately within a month or so, or a longer duration. But this is again a non-randomized study and cannot be taken, but we should try to start RT as early as possible. But at least in this study, there was no difference between patients who had radiotherapy delayed or immediately. So we do have a window. In TMH, we keep it as 3 months. If it is beyond 3 months, we say that it is better to observe. And if there is a recurrence, in that case, we would treat. And these are for patients with negative surgical margins. The other thing that we always discuss in our joint meetings is that if you have a plastic reconstruction or a flap, is it safe to do radiotherapy? Now, sometimes our surgical colleagues could be worried that if they've done a major reconstructive surgery, is it safe to go ahead and do post-operative radiotherapy? Now, this was a relatively large, a non-randomized study, but they looked at the outcomes. Now, if you look at patients who had primary closure and radiotherapy and no radiotherapy and reconstruction. Now, if you did primary closure, if you did no radiotherapy, the complications were about 20%. If you did preoperative radiotherapy, as we saw earlier, the complications were higher. But if you look at the group who had a reconstruction, if you did radiotherapy, the complication rate was 39%. And if you didn't do radiotherapy, it was 34%. So there was no difference between whether you gave radiotherapy or no radiotherapy in terms of complications in patients who had reconstruction, at least in this series. But although it would depend on multiple factors, but broadly, the message goes out that if you had a good reconstruction, then post-op radiotherapy is not a major hindrance in terms of complications that may develop. Then the dose of radiotherapy, this is not a very important paper or a study, but broadly it says that if you're doing anywhere between 55 to 70 gray of radiation, the outcomes are more or less the same. And hence, there is a need now to also look at what is the optimal dose of radiation when you are giving radiotherapy in a post-op setting and also in a definitive setting. Now, sometimes when you have done preoperative radiotherapy, you end up with a microscopic positive margin. You know, sometimes when you're doing preoperative radiotherapy for a borderline resectable tumor, and you end up with a microscopic positive margin, at that point in time, the question is, does doing a boost radiotherapy really help? Now, there are concepts that have come up regarding also known as planned positive margin or an unplanned positive margin. Now, planned positive margin means the patients who have a vital structure or a nerve or a vessel that is lying close. In them, the surgeon exactly knows that we are going to compromise the margins there, but in order to remove the tumor, we would purposely, with an intent, leave behind some disease. Now, in them, it is seen that if it is a planned positive margins, the outcomes do not really become inferior compared to the ones with negative margins. Now, the question is, does a boost radiation help? So if it is a microscopic planned positive margin, at least from this retrospective study, it is seen that boost actually doesn't really change the outcomes. So the message is, if you are thinking that you're going to have a positive margin, then it is better to do a wider resection or leave behind as less disease as possible. but you cannot always rely on radiotherapy to improve the outcomes where you have left behind disease. And that was the message from this study. Now, coming from external beam radiotherapy to brachytherapy. Now, people from, there was a lot of interest in Memorial Hospital regarding the use of brachytherapy. So in this study, they looked at limb sparing surgery alone versus limb sparing surgery with interstitial brachytherapy. And after a relatively long follow-up, it was seen that patients who had limb sparing surgery alone had local control of 69% compared to 82% in patients who had interstitial brachytherapy. So this showed that in these tumors, high-grade tumors especially, there was a significant improvement in local controls if you had brachytherapy added to limb-sparing surgery. Now, with brachytherapy does require expertise. It is more labor-intensive. It requires coordination with your surgeon, and also post-operatively, it could be more demanding in terms of manpower and coordination. So there has been a lot of interest now in IMRT, and people are looking at whether IMRT can be used instead of brachytherapy. So this was again from Memorial, and this was Khalid Elektiar's group, where again a non-randomized study, but they compared the outcomes. And then they said in their study that IMRT actually had better disease control, 92% compared to brachytherapy, where it was 81%. But the wound complication rate in IMRT was actually more than what they saw in the brachytherapy group. So it is again surprising that IMRT had better disease control, but I guess if you have not chosen your patients correctly for brachytherapy, you would end up under-treating certain areas, and you may have inferior local controls compared to intensity modulated radiotherapy. Now, we have a very strong inclination towards brachytherapy in our institution. And we do evaluate all our patients for brachytherapy wherever it is possible, and we have had good results for our patients. This is one of our studies that we published earlier of a relatively large series with both LDR and HDR brachytherapy. We saw that with brachytherapy alone, local controls were about 60%, 65% at that time. Brachy with external RT was 74%. But what we saw is that the HDR brachytherapy was doing better than LDR brachytherapy. The important one is the complications. The complications were much lesser in the brachytherapy alone group, which was about 5 to 6%, compared to brachy and external RT. This was in terms of fibrosis, distal limb edema, wound dehiscence, joint movement impairment. So it was slightly more in the, so that's why we are very inclined towards using brachytherapy in appropriately selected patients. So we have a new current series. We have actually currently more than 400 patients. And our outcomes now, this is unpublished, we're going to publish soon. Our outcomes in terms of local control is 83% at 10 years. So we are heavily inclined towards brachytherapy in sarcomas. And that is especially important in children, children where you are concerned about wound, you're concerned about bone abnormalities, bone growth abnormalities, soft tissue. And if you look at our outcomes of patients that we have treated, we treat a very young group of patients. And if you look at their local controls, 83%, overall survival, 73%. And the complications also are very few. We were treating slightly older kids earlier, but now we treat even younger patients, and we have found that it is highly, highly effective in controlling disease and reducing the complications of treatment. Then a little bit about, we are talking about stereotactic. Pulmonary metastasis is the primary site of metastasis in our patients with soft tissue sarcomas, the high-grade ones. And with the improving technology, there's a lot of interest in looking at what is the role of stereotactic body radiotherapy for pulmonary metastasis compared to metastatectomy. Now, this is a relatively recent publication, 2020, where they looked at a meta-analysis of articles that included almost 1,300 patients, and they compared surgical metastatectomy versus SBRT. What they found was that the cumulative death rate was actually lesser in the SBRT group compared to pulmonary metastatectomy group, and the survivals were more or less same. So there is encouraging data coming regarding the role of SBRT for patients with pulmonary metastasis, especially the solitary pulmonary metastasis in soft tissue sarcomas. Now, there has been a lot of interest in trying to look at which patients we can avoid giving radiotherapy after appropriate surgery. Now, people have looked at various factors, and there are no randomized trials, but people have looked at, these are some of the publications looking at limb sparing surgery alone in extremities and trunk. But if you look at the data critically, you find that majority were small tumors, low-grade tumors. And if you look at the importance of surgical margin, if your margin was less than 1 centimeter, then the local control was 87%. The surgical margin was more than 1 centimeter, the local controls were better. So broadly, small tumors, low-grade tumors with appropriate margins, you can think of avoiding radiotherapy. Now, I have just charted out 4 studies where they tried to look at, but the bottom line of the whole thing is that it is probably a select group of patients where you can possibly avoid. And who is this select group of patients? These are possibly patients with primary tumors, not previously treated, low-grade tumors, less than 5 centimeters in size, adequate margins, that is a big area of discussion, and superficial tumors. And this probably applies to high-grade tumors also. So we still have to identify a group of patients in high-grade where you can avoid radiotherapy. Now, as I mentioned earlier, the factors that truly define recurrence local is disease status at presentation, surgical margins, and there are certain histological subtypes. For distant recurrence, it is again tumor size, grade of tumor, depth of tumor, the status at presentation, and again certain histological subtypes. So one may say that why not avoid radiotherapy, and when there is a relapse, we will see if we can salvage it, and does it really impact survival if we can salvage. So again, this is large data from the National Cancer Database and the SEER database, and both these databases report that patients who had radiotherapy had superior outcomes in terms of overall survival compared to the patients who had amputation or limb sparing surgery alone. So there is evidence to say that adding radiotherapy and reducing the chances of local recurrence does translate into an improvement in overall survival, and it is seen in both these large databases. Sorry. So, so in summary, you could say that radiation therapy is an important component in the multimodality management. It makes organ and function preservation a viable option. External radiotherapy and brachytherapy have equivalent similar outcomes when they are chosen right. Radiotherapy improves local control even in low and intermediate grade sarcomas. Adjuvant radiotherapy does translate into an improvement in overall survival. Modern techniques like IMRT does reduce complication rates. We may have a group of patients very select with low-grade tumors, less than 5 centimeters, superficial and R0 resection, where you can possibly think of avoiding radiotherapy if you had appropriate surgery. And there is some evidence to show that SBRT actually helps, is a good treatment modality for pulmonary metastasis. So with that, I will stop. Thank you very much, and I would be happy to take questions.
Thank you. Thank you very much, Professor Laskar. It's a remarkable talk, as always, from you. Thank you, sir. And so I think we will begin our panel discussion. And before we delve more to therapeutic strategies, I would like to invite first our colleague from radiology, Dr. Marcel, if you would like to have some additional insights or comments on the topic. Please, Dr. Marcel.
Thank you, Dr. Mayang. Is my voice here?
We can hear it, but it's a bit like quite scratchy.
How about now?
Still the same?
You don't mind
Yeah, it's like
How about now?
yes, it's good now. Yes, please.
Okay. Thank you, Professor Laskar. It was very nice presentation. I've been dealing with radiotherapy so long ago, so I definitely forgot many things and doesn't catch up with many new advancement. And your talk really opened my point of view about radiology nowadays. So I am actually interested in one of your talk about the tumor margin, because usually we in radiology, so far we sometimes, well, it's not as easy as said in the literature. Sometimes we are got confused about defining the actual margin, especially in the area where there is a lot of peritumoral edema. So whether it is actually had tumor cells within or not. So I understand that this might be this will be actually be important for radiation oncologists in defining the tumor margin, CT and so on. What do you think about that? In your experience, how do you treat the area where there is a lot of edema? Because we in radiology, unlike pathologists definitely can see it, but there's problematic for us.
So that's a very important question. And what we as a rule of thumb do is that we do include in radiotherapy, we have this volume called GTV, or the gross tumor volume, and CTV, which is also known as clinical target volume. Now, the difference between GTV and CTV is that in CTV, we assume that there are certain areas beyond the gross visible tumor that may harbor microscopic cells. And this, we include the peripheral, the surrounding, immediate surrounding edema. And as I showed you in that study by Snow, where they sectioned the tumor and they looked at, and what is the distance beyond the tumor that harbors microscopic cells, they found that most of the microscopic cells in the soft tissue would be within 1 centimeter of the gross visible tumor. So although we try to include the edema, but we don't always go chasing the edema all through, because our volumes would be huge. And that is the reason now everybody is looking at whether 2 centimeters of margin beyond the gross tumor is probably just appropriate to cover the microscopic disease. Unless there is an area where there is, tissue handling, there is hemorrhage or a biopsy tract, those areas may be contaminated. But otherwise, if it is a fresh one, just edema, we would probably just take it as 2 centimeters. Although now there is a new concept about qualitative margin. It's not just the distance, but it is also the kind of tissue that we are looking at. And this is more of a pathology question rather than radiology. Here we look at, if we have a fibrous tissue, then even a 1 millimeter thickness of healthy fibrous tissue is taken good. If there is no fibrous tissue, then in them, the margin that is required. So this is the Kawaguchi's criteria for defining qualitative margin. The Japanese group has done a lot of work on the qualitative margin. So we don't only talk about quantitative margins now, we look at qualitative margins.
Okay, thank you very much, Professor. Dr. Maya,
Okay.
maybe?
Okay. Okay, Dr. Marcel. Okay, so thank you. And then, Dr. Umi, you want to address some points being discussed now?
Oh, no, I would like to ask for the next questions.
Oh, okay. So before we talk about radiation oncology, I would like first to invite Dr. Evelina from pathology to continue the points being discussed here. Please, Dr. Ev.
Yeah, thank you, Dr. Mayang. Good morning, Prof. Laskar. Yeah, well,
Morning.
thank you very much for sharing the holistic and interesting lectures. That it's great today that we can sit together. Prof, as a pathologist in bone of tissue sarcoma, yeah, I would like to know, yeah, how is the ideal pathology report for the radiation oncologist? So you all can be able to plan the proper treatment for the patients. And also another question is that how is the radiation treatment going to be if the pathology report failed to demonstrate any line of differentiations? As we know that sometimes here in our lab, we cannot go for the molecular study, as we know that in the WHO 2020 books, there's a lot, there's several new emerging sarcoma that need molecular study. Yeah.
So you extremely good, and I can tell you our pathologist is one of the most important members of our disease management group. You know, if we don't get our pathology right, a lot of things can go wrong. I will give you one example. Number one is to differentiate between the round cells and non-round cells, because the treatment of these Ewings and rhabdos are completely different from how we would treat a synovial sarcoma or a MPNST. And so that number one point is very important, first of all, to differentiate between a round cell and a non-round cell. Within the non-round cell soft tissue sarcomas, again, it is extremely important for us to understand various subtypes. I'll give you an example. Liposarcomas and myxoid liposarcomas, if you tell us that, okay, this is a myxoid liposarcoma, we would want to do certain additional tests. Say, for example, you have a myxoid liposarcoma of the thigh, we would like to do a sonography of the abdomen and pelvis, because we know that these tumors do metastasize to the abdominal lymph nodes. Again, epithelioid sarcomas, and very important, we know that these sarcomas have poorer outcomes compared to the ones who have synovial sarcoma. So in them, again, it is, if we know it is epithelioid, we will try to address the lymph nodal areas also, at least in terms of imaging and evaluation. So that is, again, very important. Sometimes when you have a synovial sarcoma, we know that they are sensitive to chemotherapy. And sometimes these patients, so the histological subtypes does guide us in using chemotherapy or no chemotherapy in our patients. So histology is extremely important for us in terms of what treatment policies we will have, and also in terms of radiotherapy portals. Sometimes for an epithelioid sarcoma, for a synovial sarcoma, we may, at times, if you have a suspicious drainage node, we may want to include that area. So that's extremely important. Sometimes when we are slightly confused, we do resort to translocation study for synovials, especially the SIT-SSX translocation. We do so because that is one thing that we use, one histology where we frequently use adjuvant chemotherapy. So that does define our treatment. So yes, it does help us in diagnosis. It does help us in our radiotherapy planning. And some of the histological subtypes are more sensitive to radiation. So we can reduce the dose of radiation in those patients like liposarcomas. So it is important. So the diagnosis and subtyping of tumors from pathology is extremely important. And the other thing is about the surgical margins. I know defining surgical margins is quite difficult. Our surgeons do frozen section, and so based on that, we sometimes have to revise our margins. So defining surgical margins is extremely important, and it does have an impact on disease control and our treatment policies also. As I showed you, the planned positive margin, microscopic margins positive, we do change our treatments based on whether they are positive, gross, microscopic, and the distance. And so the processing, our people are also very critical about when they process, how they process, because the tumor also tends to shrink. And whether your margins are correctly defined or not, that is very, so that is why you need to have trained residents who can actually label your tissues properly. And even the surgeons, there is a policy that you define the margins. You can't just give the pathologist a specimen to them. You have to define. So I know that it's short superior and long lateral. They put a specimen and they label it. A short tag they put long is the lateral one, and the short thread they put is superior, so that you can orient your tumor well. So it's a coordinated thing which has an impact on the outcomes for sure. So pathology is extremely important for us. Yes. So you are most important member.
Yeah, thank you, Prof. So we will try our best to give an accurate diagnosis so the patient can have the proper treatment then. Thank you, Prof.
Thank you, Dr. Evelina. And so that leads us next to invite our surgeon, Professor Fauzi Kamal, please. Prof, we would love to hear your perspectives.
Thank you, Dr. Mayang. Good morning, Professor Laskar.
Morning, Prof.
I enjoy your presentation, very nice.
Thank you.
It is improved from our knowledge actually in orthopedic surgeons. So, of course, the problem basically, I do more cases in the bone sarcoma compared to the soft tissue sarcoma. But the problem especially in Indonesia, maybe in the Malaysia as well, that patients come late. Many patients come late actually to our hospital because of the manufacturers far away from the referral hospital, the social economic, and one of the more important thing is also very difficult to diagnose the soft tissue sarcoma or to know the soft tissue sarcoma from the medical doctor. And also, even though for us, like the Dr. Eiffel mentions before, so the patients comes to our hospital as the top referral hospital with the huge mess. Of course, for examples, in the thigh, so in the posterior and the anterior compartment, the mass grow with the huge mass. Nearly all compartment, for example, in the posterior, or maybe it is recurrent from the previous surgery in another hospital. So in these situations, of course, we are very difficult to achieve the margin like that you mentioned before in all or in the circumferential area. Maybe in the proximal part or distal part, we can cut of the margin, achieve the cut of margin more than 2 cm. But because of the anatomy of the thigh, for example, of course, the tumor go into the circumferential area. It maybe compress the neurovascular structures or the bone. So in these situations, we cannot achieve the like the many surgeons maybe in the world suggest to achieve 2 cm or more than 2 cm. So in these situations, actually, many patients and also in Indonesia refuse to be amputated. So in these situations, of course, we have to know the diagnosis first with our tomorrow board meeting. After confirmed, so what we are doing is, I am one of them. I like a more aggressive surgery. So if it compressed to the bone or involve the periosteal tissue, so I cut part of the bone hemicorticotomy or more than hemicorticotomy and reconstructs after that. I like this surgery compared to the marginal margin excision and after that the radiations. But in terms of that, we deal with the neurovascular structures. So in these situations, so after we discuss with the patient, so okay, we salvage and preserve the neurovascular structures, and after that, we ask the oncoradiation doctor to give the radiations after surgery. For another situations, because of the huge mass growth of the tumors, so part of the neurovascular structure involved. Maybe the sciatic nerve, or maybe the not really involved the main vessels. So in these situations, we reserve the main vessels, and so this is the big problem for the surgeon, especially for me. So in this situation, sometimes I have to reserve the sciatic nerves by cutting part of the mass with the marginal excision, and after that, we remove all the mass in radical, look like the radical compartment in the posterior. So in these situations, we follow up the small series that we have. Even though we give the complete management or conservative treatment combined with the radiations after that, and in the high-grade sarcoma or huge mass, we ask to the Dr. Anna team from the medical oncologist to give the chemotherapy. So the problem is, like the mentions, that the local recurrence could be expected at that situations, or maybe nodules in the distant metastasis. So it is very difficult for the patients, many patients in Indonesia especially. So, or the recurrence, we deal with the recurrence at that situation, UPS or rhabdomyosarcoma, with that previously situations. So we discuss again with our teams whether we have to do the surgery first or chemo first. After that, we remove the mass, and after that, sometimes the Prof. Soehartati more aggressive give additional radiations at the situations. But some patients finally we have to do amputated because of the multiple surgery, yeah, after several times of conserve of the limb. So finally, we have to do the amputated in the 3-4 years follow-up after the some previous surgeries. So what is your suggestion in this situation? The huge mass involved the nearly all compartment in the posterior or the anterior compartment of the thigh. This is the number one question. I think it is very important. The second one is sometimes I insist to the onco radiations, even though this is the clear margin from the Dr. Apple in the low-grade malignancy, or like the fibromatosis, huge mass fibromatosis with the like the knee contracture. So we have to remove it to be a good, more good function or better functions. So I asked the onco radiation, please give radiations after that in the low-grade malignancy, even though it is clear margin, or it is the potential higher recurrence like in the fibromatosis. So what is your opinion in this situation? Thank you, Professor Laskar.
Thank you. Very relevant points that you have raised. Absolutely practical, grounded, relevant points. Two things. Number one, you said about the margins for large tumors. We have the same thing, although all of them may not be as large, but most of them would be tumors more than 10 centimeters in size. And regarding the margins in them, it is the longitudinal margin that you can easily get about 1.5 to 2 centimeters. It is literally never that you will have a margin of 1.5 to 2 centimeters in the circumferential axis. So in them, as I remember, our institution, our average circumferential margin is anywhere between 3 to 5 millimeters in our institution. We literally never. And that is why I mentioned about the qualitative margins. In your compartments, you have these fascia. If the fascia are all right, they're healthy, in them, even if you have a 2 millimeter margin with a healthy fascia, then that is considered as enough. So this, I would suggest that you read this article by Kawaguchi. He is a Japanese author. This is their concept, and it is very relevant, where we talk not only about the quantitative margins, but we talk about the qualitative margins, fascia, healthy tissue, soft tissue, bone, and based on where it is located, it may change. So radial margins, you are fine. It will never be more than 5 millimeters or so, especially in our situations where the tumors are more than 10 centimeters in size. So the next thing you mentioned about, these large tumors, like desmoid tumors. Now in desmoid tumors, they are very notorious. If you operate, it's going to come back very soon because they have these extensions beyond. So right now, in our institution, the policy is that we do not do surgery till the time the patient has significant functional deficit or has a deformity, or there is a compression or something like that happening. We do use conservative treatment in terms of systemic therapy. So our medical oncologists do systemic therapy till the time the disease progresses, and some of them do respond. Now, if you ask me what is the evidence that is available to what should be done for large tumors, now there is evidence that what you're saying is correct, that some patients where the tumor is large, you've resected it out, adding post-operative radiotherapy does help. But we try to avoid radiotherapy and surgery as far as possible in desmoid tumors currently. So if they are small, we just try to do chemo and reduce it. And if they progress in size, then we intervene and do surgery. And in these large ones, there is evidence to show that adding post-operative radiotherapy, 50 gray and 25 fractions, does improve local control in desmoid tumors. There is a publication by the Rare Cancer Network where they have very nicely shown that there is improvement in local controls. So desmoid tumors, try to avoid. Third thing that you said was low-grade sarcomas. Now, low-grade sarcomas, the normal standard convention for us would be if they are small, if they've been resected completely with clear margins, we would, and if they are superficial. So superficial, low-grade, completely resected, no contamination, not recurrent, we would try to observe these patients. But as you correctly said, that sometimes we are not sure about how good is the margin. If it is a recurrent low-grade tumor, we do back them up with radiotherapy. But that we do after case-to-case discussion in the joint clinic with the thing. So joint clinic discussion is very important for, so it is extremely important for us to all sit and also to talk about chemotherapy in these patients. We don't give for all, but large tumors, synovial, more than 10 centimeter in size, in the extremities, we do give chemotherapy, IFOS, doxorubicin. So joint clinic, so if we don't have a joint clinic, please have to have a joint clinic. And even if you cannot be in person there, it is important to have an online joint clinic. That management becomes much better, and we all know what is the best way to go ahead.
Yeah, thank you, Professor Laskar. Actually, we have the good team from my perspective, because we have already had the tumor board meeting since 1994.
Wow.
So we are very solid actually with this team, the medical doctors. So yeah, the problems actually, many patients come to us with the huge mass. So it is very, very challenging for us to manage the patient actually, to avoid the local recurrence and achieve good overall survival rates. So I think one more questions that we need, that I need your opinion. So several years ago, so I followed the lecture from Professor J. Wonder from Canada in terms of the soft tissue sarcoma management. In the low-grade soft tissue sarcoma, so I follow him actually in terms of the surgical techniques in terms of the low-grade soft tissue sarcoma. So even if the neurovascular structures involved, like they had mentioned before, sciatic nerve, or maybe the nerve, the main vascular. So I divide in the end of surgery. Of course, it will produce the minimal contaminations in neurovascular structures. So at these situations, what is your follow-up in your series? And the second one is, what is your suggestions type of radiations in these situations? Thank you so much.
So are you talking about low-grade soft tissue sarcomas where you have a microscopic positive margin after resection?
Yes, that's right.
So yeah, so if you have a microscopic positive margin, we would either look at the possibility of a revision surgery to get a negative margin. But if we feel that the margin cannot be improved any further, we would back it up with radiation therapy, even in low-grade soft tissue sarcomas. That is what we currently follow. Although there are, even Gronchi's group, Alessandro Gronchi group, they also try to observe, and they feel that if you have a recurrence, you can salvage. But it is more of a policy decision. In our center, if we can revise the margin and get a clear margin, we do it. But if there is, if we cannot achieve a better margin, we would go ahead and do radiation therapy.
Thank you, Professor Laskar. Back to Dr. Mayang. Thank you so much for.
Thank you. Thank you, Prof. Fauzi. And now that leads us to chemotherapy, which has been mentioned a few times already. Please, Dr. Anna Mira Lubis, our medical oncologist.
Yeah, thank you, Dr. Mayang. Thank you, Dr. Laskar, for your presentation. Now, we have a profound understanding that treatment modality and multidisciplinary approach is very important to improve our patient outcome. I have 2 questions, but I believe that's already asked by other colleagues. First questions, when mostly I deal with the soft tissue sarcoma who also have a chemosensitive profile. So in a very huge tumor like Professor Ahmad Fauzi mentioned earlier, when we dealing with borderline resectable or unresectable cases, what do you think and how about your opinion given perioperative chemotherapy or as a neoadjuvant compared to the neoadjuvant radiotherapy would bring a positive impact, whether we proceed to the neoadjuvant chemo or whether we as a preoperative or neoadjuvant radiotherapy to improve local recurrence in DFS and OS. And second question is in specific entities, sarcoma like a retroperitoneal sarcoma, do you treat this patient differently and how we approach this patient to bring better outcomes? Thank you.
Thank you. So to answer your first question, can you just repeat the first question?
Yeah, in sarcoma who has also a chemosensitive profile.
Yes.
Synovial sarcoma, like you mentioned earlier.
Yeah,
should
okay.
we chemo as an adjuvant or we give it preoperatively as a neoadjuvant therapy?
So in a way, what you're asking is if you have a borderline resectable high-grade soft tissue sarcoma and you are thinking of some kind of preoperative treatment, which one would you prefer? Would you prefer preoperative radiotherapy or would you do preoperative chemotherapy? So in our so I would answer it in 2 halves. One, we do definitely have evidence to say that in borderline resectable soft tissue sarcomas, giving preoperative radiotherapy improves the resectability and reduces the margin positivity that the surgeon gets. So margin negativity the surgeon gets. But we do not have data, similar data for preoperative chemotherapy. So the chemotherapy, so if you say which one would your preference be in your institute? In our institute, we would normally go towards preoperative radiotherapy. The reason is, number one, although they may be sensitive tumors, but the radiotherapy we would expect to be more efficacious as a local treatment rather than doing chemotherapy, which is more systemic. And we would reserve chemotherapy for these synovial sarcomas as a post-op adjuvant, where we have more evidence to say, like we have the Fustasi study, the Italian study, randomized trial of adjuvant chemotherapy versus no, and there was a survival benefit. So we would more reserve our chemotherapy for an adjuvant setting in patients with synovial sarcomas, high-grade tumors, and in the extremities. We would, so because there is evidence in them. So there is more evidence for the benefit of chemo in the adjuvant setting rather than in preoperative setting. So we would tilt towards pre-op RT and keep chemotherapy for adjuvant therapy. So that is the first one. And the second one was on
Retroperitoneal sarcoma.
So the RP sarcomas, there is a different set of people who are extremity surgeons do not do. I'm in the retroperitoneal sarcoma group also. So there are what has happened over the years is that we have become more aggressive in terms of what kind of surgery we are doing. There is not much that has happened in terms of chemotherapy in the retroperitoneal sarcomas, except for some liposarcomas and myxoid liposarcomas where they seem to be sensitive. But what has greatly changed over the years is the extent of surgery that we would do for retroperitoneal sarcomas. So our use of radiotherapy, the chemotherapy would primarily be for our extremity sarcomas in our institution.
Okay, thank you, Dr. Laskar.
Thank you. Thank you, Dr. Mira. And now I think we could go to more radiation oncology questions. There are also many questions in the Q&A box. I noticed. I hope we will have time to address them all. But first, I would like to invite Dr. Umi to have your questions also to Professor Laskar, or comments or discuss on some points, please.
Thank you, Dr. Mayang. Greeting, Prof. Siddhartha Laskar, Prof. Soehartati, Professor Fauzi, Dr. Anna, and Dr. Evel, and Dr. Handoko, and other participants here. First of all, I would like to introduce myself. My name is Umi Mangesti. I come from different hospital than the other panelists, from nearby hospital, Dharmais Hospital, in West Jakarta. And I would like to ask you some questions regarding to the presentation that is very interesting, Professor. But I would like to know more about inoperable settings. Whereas a patient in Indonesia that came to the center I work is more to the inoperable cases, and as the same as like Professor Fauzi, Dr. Anna Mira, and also other colleagues here who receive type of patient that is more to the inoperable setting or inoperable case. In how do you manage for the inoperable settings that is regarding to the extent of the tumor, especially for the tumor that is has subtype of chemo resistant subtype, and how do we manage of the radiotherapy in that kind of situation? Whether is there any experience of having chemo or radiosensitizer or in a chemo concurrent setting? And the next question is about radiation setting in recurrent or recidive cases, and what cumulative dose do you perform and for the radiation settings, and in what timeline? Whether it is 1 year that we can, after 1 year that we are able to do irradiation, or before 1 year we can also do the irradiation, but in different cumulative dose. And the next questions is about the progressive disease cases and when during the treatment. So in what step, I would like to ask the experience in your center, what step of the assessment, what we have to do when we see or we face the progressive during treatment. And the last question is about the early detections. I mean, we both know that sarcoma is difficult to do the early detections. We oftentimes find the situation or the case when they got the symptoms. And is there any management in your center based on your experience about doing the early detections, like molecular examination or genomic in your center? Thank you for the experience. Thank you, Professor.
Thank you. So you have 4 questions. I'll address the first one. So the first question that you had is, what is the role of definitive radiotherapy for patients with inoperable non-round cell soft tissue sarcomas? Is that right?
Yes.
So, so when we have patients with large tumors, we critically evaluate whether it is clearly inoperable or is it borderline. Now, if it is borderline, we do the preoperative radiotherapy and then call the patient back. Now, if it is clearly inoperable, then we look at the feasibility of getting a R0 resection by doing a ablative surgery. So we do that. So if, for example, it's in the lower limb, in the calf area or in the thigh, where we have a localized tumor which is clearly inoperable, which is huge in size, we know that by giving definitive radiotherapy of 70 Gray, we will not be able to cure this patient. In them, we do discuss about ablative surgeries like amputation in them. And because by doing an amputation in these patients, we can still have a disease control and maybe have good functional outcome with the artificial prosthesis in the future. So we look at whether this inoperable tumor is very large that cannot be eradicated or controlled with radiotherapy alone. And very rarely we will find a tumor which is about 5 centimeters in size or 6 centimeters in size and it is inoperable. Most of the inoperable tumors would be at least 15 centimeters in size in the launch axis. So a 15 centimeter or a 17 centimeter, we cannot eradicate with definitive radiotherapy to the doses of 70 Gray with photons. If we do with carbon ions or something later on, we don't have no experience with that. But with photons, we do not feel that we will be able to eradicate. So we do counsel the patients for an ablative surgery in terms of amputation and do a prosthesis. So that's...
So, how about it is in the head and neck area or intra-abdominal? That is non-surgical for ablative surgery.
So in them, we go to 70 Gray of radiation. After this kind. So for extremities, I was talking about, but if it is the head and neck area and in the abdomen, we try to push in as much dose as possible. In abdomen, it is very rare that we are able to push in that, but we do push in that kind of a dose. And I do have patients whom we have treated with 70 Gray, even old people, 70-year-old, 75-year-old, who have abdominal tumors that are not resectable, we've given full dose radiation. And sometimes when the general condition of the patient is not very good and they are old, we even have done hypofractionated radiation, like 5 Gray per fraction, 7 fractions to the tumor. And it's kind of palliation, but we have some long-term disease controls also. So we do it case by case. But in head and neck and abdomen, we would probably go ahead and do definitive RT. The fractionation may change based on the clear intent. And as I said, normally we would try to do 70 Gray in 35 fractions, conformal, very tight portals. But in some of them, where we feel it is probably palliative, commuting would be a problem, we do 5 Gray per fraction and 7 fractions. So 35 and 7 fractions we do. And we have some long-term disease controls with them. So that is about the second thing was re-radiation for recurrent tumors. In our joint clinics, we have a policy that we try to go with curative intent of treatment only if the DFI is more than 1 year. If the disease-free interval is less than a year, then we know that the natural history is not, the biology is not good. We may not be able to cure this patient. So we are not very aggressive. But if we have a patient which is has a DFI of more than a year, then we try to be aggressive. And if it is a local recurrence only, we try to do surgery, do a reconstruction, flap if required, and we do evaluate for radiotherapy. But when we are doing salvage surgery, we always evaluate for brachytherapy, especially for these patients who have received radiotherapy earlier, because brachytherapy is much more safer as a re-radiation tool, because the volume that you would radiate is much lesser. And we would do full dose brachytherapy of 36 Gray in 9 fractions, which is our standard brachytherapy that we do for our thing. And if we are not doing brachytherapy, and we have done a primary closure, we look at the wound, if everything is all right, negative surgical margins, we would lower the dose a little bit in some patients, but we would try to push in at least 50 Gray in 25 fractions, if not 60 in 30 fractions. but we would not go to 70 gray. So our re-radiation dose with external RT would vary between 50 gray to 60 gray. Yeah. And if at all there's gross residual disease left behind, we may just do a very coned down volume to escalate dose to that gross nodule only to 70 gray. But we would evaluate the wound, and it would also depend on the reconstruction if they have done. Sometimes, we remove the entire recurrent area, previously radiated area, put in a new flap, and then it's fresh tissue. So we can go full dose of radiation. So that's the second one. The third one is progressive disease. You mean to say progressive disease after surgery?
Progressive during treatment, sir.
That means you're doing definitive radiotherapy?
Yes.
Then it would be palliation. See, if, number one, we would not want to treat non-round cell soft tissue sarcoma with definitive radiotherapy. If we are treating this patient with definitive radiotherapy, we already know we are doing inferior treatment. And that inferior treatment, if it is progressing, it is palliation. We would call it best supportive care and just do symptomatic treatment because we can't do anything much. Yeah. Or maybe we may end up doing an amputation if there is no metastatic disease elsewhere, so that at least, you have some local control, but we would look at it. So it would become best supportive care most of the times if it is progressive disease. So next one is early detection. Not really. I'm not aware of any screening tool that we have for detection, early detection of soft tissue sarcomas. But what we clearly do is support groups and awareness programs. So, the people, we have the sarcoma support group. So when they go back home to their communities, they go and tell them. But if you ask me, is there a screening tool by which you may pick up? At least we are not aware of any effective screening tool that can pick up soft tissue sarcomas earlier. Yeah, we don't really have that. We have a follow-up policy for sure for our patients who finish treatment. We did a randomized trial to see whether more aggressive screening, that means follow-up, like CT scan, MRI on follow-up, and all these things. And we've proven in a randomized way that it is no point doing all these aggressive CT scans and MRI on every follow-up. And we also don't believe that the follow-up interval should be very short. So there is a paper, it's the TOS trial that my colleague Dr. Puri has published. So that's a follow-up policy. Yes.
Thank you very much, Professor. But one question that haven't been answered about, is there any role of chemo radiotherapy concurrent setting for radiosensitizer?
Some people have used, isolated limb perfusion and other things earlier, and there is some interest in using isolated limb perfusion along with radiotherapy. People have also used hypothermia for large tumors, but they are not really something that we could equate to what we would do in head and neck tumors, say, for example, where you use cisplatinum as radiosensitization. So we do not really have anything in terms of radiosensitization, and that primarily would be because we would normally operate and remove it and then radiate these tumors. So that's probably the reason. But the only thing I can think of is isolated limb perfusion followed by radiotherapy that people are doing now. But that is mainly for kind of palliation, actually, not really as a curative treatment. Yeah.
All right. Very, very much thank you for Prof. Siddhartha. It's very valuable lesson and very interesting lecture. Now I give to Dr. Mayang as moderator my screen.
Thank you, Dr. Umi. And well, we have almost reached our 2 hours time. We still have one more panelist, Dr. Handoko. I'm sorry, you have very limited time as the last panelist. Please, Dr. Handoko.
Yeah, thank you. Thank you, Dr. Mayang, and thank you, Prof. Laskar. I truly enjoy your lecture. Right now, we generally treat soft tissue sarcoma in post-op setting, And then we usually use 3D after I listen to your presentation. Maybe we'll try to spare the bone and the subcutaneous tissue next when we have the sarcoma patient. And then what we actually have the modality is we have the catheter, flexible catheter for implant brachytherapy, but we have never done it for some time. You mentioned that it is useful in very selected cases, maybe in what condition, or and I mean, we are very keen to utilize that modality because there are a lot of technical challenges. Maybe you can describe it in brief. Thank you, Prof. Laskar.
Thank you. Thank you for bringing up brachytherapy. That is I'm so fond of brachytherapy. If you've given me a chance, I will do brachytherapy for every soft tissue sarcoma. And so brachytherapy is utilized and is very effective, equally effective as external RT or a combination in select patients. Now, what is the meaning of select patients is what I'm trying to tell you here. If you are able to cover the tumor bed adequately with your brachytherapy catheters, tumor size or location is not a contraindication for brachytherapy. So you can treat brachytherapy for a 2-centimeter tumor, you can do it for a 5-centimeter tumor, you can do it for a 15-centimeter tumor, as long as you are able to introduce your brachytherapy catheters into the tumor bed appropriately. Now, that appropriately is very important. The tumor bed, so if you are not able to cover the tumor bed adequately, then brachytherapy is not the indication. So if you have a flat bed, if you are going into the tumor bed adequately, even if it is 10 centimeter or 15 centimeter, doesn't matter, you can still treat with brachytherapy. But if you have an undulating kind of thing, where in certain areas your tubes cannot go down like this and come out like that and go like that. So in those areas, you will underdose the tumor bed. In them, brachytherapy is not. Say, for example, between the radius and ulna, there is a tumor in between going. So if it is just superficial, you can treat it. But if it is going in between, you cannot. In certain areas in the interscapular area where it is so in the axilla, some areas. So there you may not be able to do. But the broad rule of thumb is if you are able to introduce your brachytherapy catheters into the tumor bed adequately with margins, then brachytherapy can be done for all those patients. So it is extremely useful. And the volume of tissue that you end up treating is hardly about 1 to 2 centimeters. Are less. But we have to be careful when you are actually very close to the skin. There are some technical challenges that you have to keep in mind. But brachytherapy is great. It is a great way of treating, especially in children. And if somebody is interested, I'll be very, very happy to help you out in brachytherapy. I'm very, very passionate about brachytherapy for these patients. So it's extremely, you've seen our outcomes is 83% at 10 years local control with brachytherapy. So it is extremely good. And our complication rate is 6 to 7%. So it is good. It is technically challenging, more effort, more coordination required. But look at if you're doing brachytherapy alone, the patient can go home in 7 days' time. Whereas if you're doing external RT, you are spending so much more time in the hospital coming. So you can help the patient. The cost is lesser, the complications are lesser, the disease control is the same. But we can have a separate session on brachytherapy. I'll be happy to show you. I do brachytherapy for orbit. I do brachytherapy for neck. I do brachytherapy for limbs, chest, for prostate, for urinary bladder in children. So we do brachytherapy literally for all sides. It's very exciting.
Okay.
The location where the positive margin, we ask the surgeon to put the clip also. So when we CT it, we know where's the location that we have to treat. Is that correct? That's what I imagine.
Yes, yes.
Okay. Thank you, Prof. Laskar.
Thank you.
Thank you, Dr. Handoko. Well, we have, it has already passed our limit of duration. And I think your team from Tata is already chatting me to ask if they can have you back.
Oh.
And because Professor Laskar have another session, I believe, another commitment after this. And so yes, we realize there are many unanswered questions in the Q&A. If it's okay with you, Prof. Laskar, if I could copy their questions and email it to you, if you don't mind to answer.
We can
them.
have 1 or 2 quick questions if you have, and then, you know.
Okay.
Yeah.
Okay, if it's okay with you, then we can have there's a question from Dr. Steven. Dear Professor Laskar, do we need bolus in every post-op STS to cover those in the scars or the skin?
No, I never use a bolus. We never use a bolus. We don't have to do that. And although we say that scar recurrence is an issue, but if you look at literature, there'll be very few publications where actually you'll find that the recurrences are in the scar. And that cannot be reduced by adding a bolus. So to answer your question, is bolus required for every patient? No.
Yeah. One more. I think there are the brachy. Well, we have discussed a bit about that already. There's a question from Dr. Elia. For the limb area, it is often difficult to do image registration between MRI and CT. Do you have any solutions or tips regarding this issue? And do you have any clue on the role of deformable registration for a problem like this?
We used it, you know, you have a very relevant question here. See, when we have the preoperative imaging, every patient will have a pre-op MRI scan with them. But the problem is when you're doing a radiotherapy planning, whether you are using without a vacuum cushion or otherwise, the entire anatomy of that area would have changed. So it is extremely difficult to really fuse, but we do co-register and see approximate extent of the tumor that was there related to bony structure. So what I would do is I would try to match the bony structures and see what is the extent of soft tissue. But otherwise, the compartments and everything is completely distorted when you have done a surgery. It's very difficult to match that. So very valid point. But yes, fusion can help you guide your CTV, but it will not be highly accurate. We failed in trying to match it completely.
Okay, thank you very much. And I think we will send the other questions to you, and we will share it in our IROS group. So if anybody else have questions not typed in already, please send me the questions, and I will forward all the questions to Professor Laskar. So thank you very much, everyone. And to close the webinar, I would like to invite Dr. Ben to give the closing remarks, please.
Thank you, Dr. Mayang. And I'm sorry, everyone, for taking another minute of your time. Again, I would like to thank the organizers for a very, very well thought topic, and for Dr. Siddhartha for preparing a very insightful lecture. Thank you, our panelists. The discussion was very interesting, very useful as well for me. And I'm sure this is very useful for our participants, both the practicing radiation oncologists as well as the residents. So again, thank you very much. We really appreciate everyone's active participation despite this being a weekend. I would like to express again our wishes that our session here will be useful at the end for our patients. May we always improve the management of our patients, and in this case, our sarcoma patients. And again, our best wishes for everyone. Have a great weekend. Hopefully we can meet again in another session in the series. Thank you very much. Thank you very much, Professor Siddhartha, Professor Fauzi, Dr. Marcel, Dr. Anamira, Dr. Evelyn. Thank you, Dr. Handoko, and Dr. Umi, I think.
Thank you.
Thank you very much.
Thank you, everyone.
Have a great weekend,
Thank you.
everyone.
Thank you,
Have a
Prof.
great
Laskar.
weekend.
Professor
Bye,
Laskar.
Prof.
Thank you, Prof.
Thank you so
Thank you.
much. Give my regards for
Thank you,
Bye.
Prof.
Dr. Ajaib.
I'm sorry I lost a lot of
Yes.
time because I have something to do. Bye. Thank you.
Bye, Prof.
Bye, bye, bye.
Bye.
Thank you,
you so much.
Prof.
Bye, bye.
Bye-bye, everyone. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Salam warahmatullahi wabarakatuh. Thank you so much. Thank you so much.